big disaster. This has got to get a revision. Here's an immediate post-op. You can see poor apposition, poor cut position, poor cut angulation. This will not heal uneventfully because it was not done very well. And again here, fixation failure, very similar to this case, the classic triad, secondary loss of reduction of the plateau, tuberosity, avulsion fracture, and fibular fracture. Bottom line is you don't want any of these to be your case. And what we're going to do in the next 50 minutes or so is give you some tips on how to avoid this and get the bone to heal very well in the right spot at week 6. That's really what we're looking for. And that really starts with the basics. We have to consider that, a bone plate and a bone screw are not really individual implants, but they're an implant system. They're designed to work together. And for them to work together, various very specific parameters have to match. And so this is an image provided by Tim, and it shows a cross-section of the standard dynamic compression unit, which is the standard hole in the old DCP plate. This was designed way back in the late 50s, early 60s by the AO. And what we can see is that the screw head, which is spherical, goes down a very shallow angled part of the plate. And this is called the engagement lead-in. And I know when I learned about bone plates, I was taught that it's this slope in the plate hole that creates compression. But actually that's not true. It's this engagement lead-in that generates compression. The slot is simply room for the screw head to travel during compression or subsequent compression from another hole. So it's really this part of the hole that we really never talked about in our courses on how bone plates work, not the slope that generates the compression. All these little angles have to match perfectly so that the screw head doesn't undergo excessive stress and break off the screw shaft, for instance, and that it generates the appropriate amount of compression. We don't want to compress the bone too much because we could break the bone, and yet we don't want to do it too little as far as distance goes because we won't generate enough compression at the osteotomy. So there's a lot of interplay between the design of the screw head and the design of the plate hole that make this plate and screw system work together correctly. If we go in further detail looking at the screws themselves, the ideal spot for the screw head to touch the plate is here along this black line. And that will be the safest to prevent any damage to this plate, screw, or bone. If the plate screw, if the screw hits the plate too high, that creates a load sideways and that can pop the head off the screw. If it's too low, it generates too much axial pressure, which might strip the bone or pop the head off the screw. And this is why you don't want to mix and match implants from different companies, because who's to say that a screw from brand Y matches the plate angle of brand X? The engineers of those two companies have not made sure the angles match. Maybe they do, maybe they don't. The best advice is don't do it because you want to make sure all these little details are correct. Otherwise, you may have implant-related complications, which could result in the need for a revision surgery, which is now your problem because we've used implants from different companies. Here's just an example. On the left, we've got a dynamic compression hole, or so-called DCU, the dynamic compression unit. This is the exact same thing that was shown in that cross-section. This is a drawing of the way it's designed. This is the real plate hole, and here's the screw head that matches it. These happen to be DPS implants. A few things are noticeable. One is that the junction of the screw head to the screw shaft has a very smooth transition. This is important because there's a stress concentration at the junction of the head and the shaft, and we don't want the head of the screw to break. Let's look at this one. If we look at this screw, there's an obvious line where the screw head and shaft meet. This is not a smooth transition. this screw head is more likely to break off than this one, simply because of the design. Let's look at the corresponding plate hole. This engagement lead-in is too steep. It doesn't match the screw spherical surface correctly. This hole will not generate compression. Even though it is a seemingly compression hole, it does not compress. How do I know that? Because we tested it in the lab. The screw goes in the hole, but the hole doesn't compress the bone fragments. So if you look at this plate in your hand, you think, oh yeah, compression hole, great. But if you use the plate, it doesn't compress and you wonder why. The reason it is the plate hole is not designed correctly and doesn't match the screw head. So engineering in this plate is not very well done. So let's move on to the arc plate. In order to make the arc plate, which is the new Tplo compression plate from Tplo, we had to look at how the plate and the screw interact. And this is all Tim's work. And what we need to do is make sure that when the screw generates compression, we are not creating abnormally high stresses that could break off the screw head. So this is so-called finite element analysis, basically color coding related to stress. Red is high, blue is low. And you can see that this screw in this hole, there's stress at the screw head shaft junction, but it was calculated to be tolerable within the limits of what the screw could withstand. And it was both in axial load as well as side loading. So we had to make sure that the plate and screw interfaces didn't generate too much force on the screw head to break the screw head off. I know other groups have worked on generating cranial compression with Tplo plates and have had screw heads break off because they weren't able to optimize the interaction between the plate and the screw. Now you have to remember, when you insert a screw, you basically turn the screw. A screw has been termed the most simple of machines because when you turn the screw, it either advances into the substrate, or if you turn it the other way, it comes out. So turning is made into a movement, and that is the basis of a machine. We have to remember, when we tighten a screw, it exerts a force on the bone. If the screw generates so much compression, it can strip the bone. So engineers have to also look at the forces applied to the bone during compression, cranial and distal, to ensure that we're not going to fracture the bone or strip the bone. And recently, a publication came out relating a certain screw to bone fractures in the Tplo. And this could also be related to engineering of the screw bone interface. Maybe they're not optimized, and now we're seeing some fractures, for instance. So a lot of work behind the scenes to make what appears to be a simple thing that we just stick on the bone and tighten the screws actually work. So why an arc Tplo plate? Well, if we go back to the standard Tplo plate from Tplo, what we can see is that many times the plate has a very slight cant, or angle, and that's the best fit. We put it where it fits best. And so the observation that the best fit resulted in a slight angle made us wonder, wouldn't it be nice to have a plate in which the the plate head, the top, was angled back so the shaft could still be going straight down the bone, but the screw head could be positioned, or the plate head could be positioned on the tibia where we like it. And so making this observation, we did some measurements and came up with the approximate angle that was average for most cases. Is this a problem? Not really. In most cases, putting the plate at a slight angle, not a problem. Particularly here, you can see the distal screw is still centered between the cortices. But occasionally, that distal screw can be close to or touching the cortex. And if you had the unlucky happenstance of drilling straight through the cortex, you might end up with a tibial fracture because you've damaged the cranial cortex. So ideally, plate shaft goes straight down the bone, plate head is in the best position. And so that gave us the idea, let's go ahead and make a plate with a plate head that's tilted back. However, if you do that, there's a negative. And that negative is that when the plate is tilted at this degree, the compression that this plate generates is along this green arrow. We're not only compressing distally, even though the plate holes only compress distally, since the plate is at an angle, distal for the plate is angled on the bone. And so if we create a plate with a head that's tilted back, we're only going to compress straight down the bone and no longer along the green line. So we set out to devise a way to generate compression along the green line in this picture, despite having a plate head that's tilted back. I have to say it wasn't easy, and it took a few tries to get it right. And what we came up with is this sequence of special holes. And now, grossly, if you look at these holes, you say, okay, gee whiz, it's a slot, a combi hole, a dynamic compression hole. What's the big deal? Well, engineering-wise, there are subtleties to each of these that make them different. These three holes are not the same as any other plate holes ever made before. This is a slot hole. It's angled at a certain angle, which is related to the angle of the head of the plate, to provide compression down that green axis that I showed you. This looks like a combi hole, but it's an elongated combi hole. A combi hole really only allows compression at its own hole. In order to compress with a subsequent hole, we need a longer DCU part. And you can see there's a little bump out here, which accommodates the screw head angling as this screw travels in this hole. Because this is angled, the screw head actually angles slightly in the hole, and this little recess accommodates the screw head. This is, in fact, a standard DCU, as in an old DCP plate, but there are some other features, a little bump out here, it's slightly different. So the bottom line is there's a lot of engineering involved in making this plate work and designing these holes without popping off screw heads. So how does it work? Well, we want compression along this blue line. That's generated by this slot. And so what we do is we apply the plate by putting the first screw, the cortical screw, in what we call hole number 4. So 1, 2, 3, hole number 4. We put the screw in, not super tight, but snug. We then put a screw in a load position in the combi hole, and then we place at least 2 locking screws. When we tighten the screw in the combi hole, the screw head moves the plate distal with respect to the screw. Because of the angle of this hole, the plate will move cranially and distally at the same time, generating compression along this blue line. Once that screw is tight, we can then put a second compression screw, so another screw in a load position in the DCU. We snug that up. We loosen slightly this screw. We alternately tighten these 2. Once fully tight, we fully tighten this screw. We then place our last locking screw, or if we've already placed all 3, we're done. And that's the sequence of compression. So this picture basically shows the plate starts here, it's more proximal, and it's straight down the page. And when we're done, it's tilted back and it's further down the page because we've taken the plateau, we've compressed it cranially and distally a certain amount. Now remember, if the bone edges are perfectly opposed and touching, we're going to generate compression just like this. I'm pushing my fingers together, but now I'm not. But not much moves, right? We're not seeing big motion. So how much you see the screw heads move in the plate holes actually depends on how well opposed your osteotomy was before applying the plate versus after, once compression is generated. If you have perfect reduction with perfect apposition, you're going to generate a compression force without seeing motion because nothing is moving, it's just squeezing together. So now we're going to go ahead and walk through a procedure. And this is a procedure that Ross did, and we're really going to start at the beginning and just give some little tips and tricks. Our hope is to generate some questions, not only about the ARC Tplo plate, but Tplo surgery in general, tips, how to make it efficient in your practice. Ross has got a very efficiently run practice, so he's an expert on all of this stuff. And so what we're going to do is just play a few video clips, and Ross is going to narrate and tell us what's going on. So Ross, can you give us some of your philosophy on jigs? Obviously, there's a slide here on jig pin insertion, so we're going to use one. Why is it important? How do you use it efficiently? And do you recommend it in every case?
Sure. Yeah. The answer is yes. We use jigs for every single case, and we do it for a variety of reasons. We use jigs because it helps establish alignment. It helps maintain alignment. It helps avoid introducing deformities like valgus varus or torsional deformity after osteotomy. It helps maintain control the fragment after osteotomy. So we find there's a lot of advantages to this. And why it's important to start with something as simple as proximal jig pin insertion. I know people are probably tuning in because they want to learn about this plate and how this plate works. But I believe that this entire operation starts with this proximal jig pin. And a poorly placed jig pin, either too proximal, is going to cause damage to the subchondral plate, and you should feel that because your jig pin will be very hard to insert through that dense bone. If it's too distal, if it's too cranial, it's going to now force your plate to be in a more cranial position than you might like. And so having this in an ideal location is very important. So we start by inserting a small gauge needle, a 25 gauge needle. And this is largely based on our plan. I think when we're digital planning now, we're planning where the osteotomy is, we're planning where the plate may go, but I'm also planning where my jig pin goes. And so that pin for me goes just above or sometimes even just caudal to the medial collateral ligament. And my pin goes in either in the caudal third, sometimes just behind the MCL. Early techniques, Slocum described putting the pin right through the middle of the MCL. And I can't say that we ever saw any problems with that, but we try to be as sparing as we can of that ligament. But remember where that pin goes. That pin does not go in the middle of the plateau segment. It goes just above, usually 1 to 2 jig pin widths is how I measure that, this being a 3.0 millimeter pin. 1 to 2 jig pin widths below our needle. We also use that needle to then help measure where our exit point. Again, when we talk about early planning descriptions, we talked about D1, D2. Maybe a decade, 15 years ago, we started measuring this D3 measurement, which is really where the cut exits out the back of the bone. And that will vary again based on our plan. And so it is not necessarily the radius of the saw blade, because if we have a centered osteotomy based on the middle of the joint and the eminences, that is not the same as if we plan from the slope of the tibia, the downward slope of the tibia, to where our desired exit point is. So essentially just match your plan. For me, with the downward slope of the tibia, that usually means that our distance, this D3 distance, is going to be 1.5, 2 or so millimeters less than the radius of the saw blade when we make a centered osteotomy. So this first step is super important. So we place our proximal jig pin in an appropriate location and perpendicular to the bone.
Great.
And so here you see the proximal jig pin having been inserted. We apply the jig, and because the tolerances are very, very tight, the hole in the jig arm is intended to receive this 3 millimeter pin. And we've already now installed our distal jig pin. I try to make that as low as possible in the bone. I do not put it through the primary incision because, again, we're trying to avoid creating stress concentrators, a hole just distal to the bone plate. So we make our distal jig pin as far as we can distally in the tibia. And if our pins are parallel to each other, the jig should swing without being restricted. If there's binding of the jig, and if they don't swing, your jig pin, your distal jig pin is tilted relative to the proximal, either craniocaudally or medial to lateral. So by seeing this freely moving jig, we know those two pins are in perfect positions.
And Russ, can you talk about the consequence of having the jig pins kind of sprung and preloaded? They're not straight, and now there's a force applied to the two of them.
Right. And so that's a great point, Mike. And so there's this idea of jig swing. And if we don't have that, you can certainly apply the jig and maybe unknowingly adding a force to those pins so that when you then make your osteotomy, the bone segments will pop relative to each other because they're really just going to conform to what the jig is now dictating. And so we sometimes talk about seeing no pop. And no pop means that if we make our osteotomy and our osteotomy is parallel to our pins are parallel to each other, there should be no force applied to those segments. And so they don't distract, they don't rotate upon each other. And so that's another important reason why those jig pins need to be placed appropriately relative to each other.
Great. And that, I mean, it's a subtle observation, but it's a sort of a double check that did you do a good job with the jig or not? And if not, what do you need to fix for the next time? Because if the segments pop apart or go into a torsional malalignment, now you have to fight against that when you reduce it and put the plate on.
So in this next segment, I do pack behind the tibia. I elevate the muscle off of the back of the tibia, and from its entirety from medial to lateral. What you don't see in the video, I actually put my finger back there so I can feel that lateral corner. And what we do, and it's important, I know these sound like very simple concepts, but there are good ways to pack and there are not as good of ways to pack. And whenever we're packing anything, whether it be a wound or here trying to protect the tibia for the osteotomy, we want to pack from deep to superficial, which means the first pieces of gauze are being pushed all the way to the lateral side, as deep as possible, to the extent of our elevation, and then pack from deep to superficial, and you can see the entire gauze spin has been placed. The blue ribbon that you see there is a radio-opaque marker, and while we hope to not ever have to experience this, the importance of the radio-opaque marker is in the event on a post-op x-ray, you see that ribbon, that metallic, that radio-opaque ribbon, you left the gauze in. And it is not a big deal today. It means you do have to go back and make a small little keyhole incision and take it out, and that's a relatively easy thing to do. That will be a problem in about 2 or 3 weeks, and now it becomes a major problem in order to deal with. So we always use radio-opaque gauze in our orthopedic cases when we're packing. Questions, Mike?
Yeah, and one thing to mention, you can see that Ross has left part of the gauze showing. And I remember when I first learned to do this, we would stick 2 or 3 or 4 gauze in there and pack them in, and they'd be gone. You couldn't even see them. You're much more likely to leave it behind if you can't see it. So if you leave a little tag of it showing, you're going to remind yourself to take it out because you still see it. Whereas if you shove it in there and don't see it anymore, you're more likely to forget it. So that's just a little very simple trick. Make sure you've got it showing. And also, when you're cutting, don't go cutting into the gauze, right? The gauze is there just for protection. You're not supposed to cut through it or into it. So cut the bone by rotating your hand, but try to avoid jamming the saw into the gauze because, certainly you can cut the gauze and leave debris behind, but that's because you're not doing a good job of avoiding the gauze. The gauze is there just in case, not as like a bumper that you're supposed to smash into.
Yeah, and I think we discussed, Mike, there's also difference between gauze, and some is very sort of filamentous and has a lot of loose fibers, versus better quality gauze that resists that. And so, again, simple concept: choose good quality gauze, use a radiopaque marker.
Great, and here we can see in this video the planning that you've done, and so this is the extent of planning you do all the time.
It is, and I use an ortho view, and that's what you're seeing here. I think there's a couple other systems out there that people are commonly using. I like this system. Unfortunately, it's no longer available, but and no longer supported. But it is a nice system, and it helps us with Tplo, planning where the osteotomy goes, planning our landmarks for where the saw blade enters the bone, where it exits the bone caudally, and then placing the implant. And it has this feature where we can draw out screws, so we have an approximate idea of what screw lengths should be. And so we display that, and it's kind of, you can't see it in this picture, but then there's basically a small little table, little recipe that we put on top of the template, which gives me all my key information. What is the pre-op slope intended, which we set to 5 degrees. Sometimes what you've rotated if we feel like we want to give it a little bit more. And then our key reference points for where the saw blade goes. We then do test fit the plate, and so before I do anything, I check again. You'll see that I guess I'm more of a dissector than some people, and so I clean the bone. I remove buttress, and oftentimes there's a triangular piece of soft tissue. Sometimes it's very firm, and I tend to remove that. The plate, and really all these plates, we talk about the relationship between screws and plates as a unit, but I guess I would also add that there's a relationship between the plate and the jig. And so as you see, as we're test fitting the plate, these plates are designed so that the head of the plate works with the proximal jig pin and kind of fits in that little space. And that's just a really, really, really nice feature, so that and then as we cut the bone and rotate it, that jig pin will move more proximal and then clear ways so that we can then insert our threaded drill guides.
Yeah, and it's important. I mean, it's obviously a system that's made to work together. And as you said, when you put that first jig pin in, if it's in the right spot, you basically know right where your plate's going to go, which is that you snuggle it up against the jig pin, and that's where the jig and the plate fit together. And just like you said, if you get your jig pin in the wrong spot, now your plate can't fit up where it's supposed to go, and it's all downhill from there. So to me, the jig really helps set the stage for everything else, and it's a double check that everything is fitting the way it's supposed to.
Yep. So the start of the osteotomy, we want to have the shaft of our tool. In this case, this is the oscillating saw attachment for the unium. We want to have that parallel to our jig pins. So again, our jig is helping establish alignment. I tend to use my thumb, or I'll use my thumb and my index finger to help stabilize the blade. Some dogs have a tremendous amount of triangularity to their proximal tibia. So caudally, it's much more medial. It's higher up towards the ceiling, and there's a tremendous amount of downward slope. So trying to control that cut can be challenging. So I'll stabilize it. There are also tools, fence-like tools, the osteotomy guides that come with this jig system to help you place this in an appropriate location. So we begin our cut, we stabilize the saw blade. You can see in the bottom left that my assistant is using a lot of lavage, and so it's super important to cool this blade. When we talk about bone healing, not burning bone is important, and for anything, I think driving K wires, drilling bone, sawing bone, we know we can burn bone, and if we burn the bone, we're killing the bone. And now you're asking the body to do more work because it has to now somehow has to deal with necrotic bone tissue. So keeping this cool is important. We make a small kerf so that we can then remove the blade. I'll often then check my plate position one more time, because if I need to, I might even still be able to change how I'm going to make that osteotomy. If we like what we have, we're then going to mark the bone.
And that's a good point. I mean, saws get dull, and you either have to replace the saw, or if it's one that can be sharpened, sharpen the saw. But all these little things add up to the ultimate outcome and or complication rate. And our job is, let's try to get the complication rate as low as possible. And to do that, it's every single little detail along the way that adds up to what is your ultimate success or complication rate.
And, one of the things that has come up, we talked about, and you'll see in those pictures, that I do these operations with an assistant, and I do them with an assistant every single time. I do not do this by myself because I can't saw the bone and lavage at the same time. You'll see in subsequent images placing the temporary fixation pin. Well, it's hard for me to maintain the reduction exactly how I want it and drive that pin. So I think having an assistant is important for this, and it makes things go smoother, faster, better. So we're in this series, we're preparing to mark the bone, and so again, I do clean this off, and I clean it off so I can see it, and I feel better having a clean surface. We're then going to use an osteotome to make an initial mark, and where exactly that mark goes is probably a little less critical. It's in the cranial third or so of the proximal segment, and I use an osteotome still today. I make a small little mark with a 6 millimeter osteotome, and then I'll lever that osteotome gently back and forth, and then use cautery to make a small little burn mark as to where that initial reference point is. I think that the next step for us, and we routinely do this with saw blade radiuses in excess of 24, so the 24s, 27s, 30s, and above, is less so with the small blades like a 12. I think that with a larger radius, it becomes important to mark the bone on the proximal segment. And so we're measuring our distance from that we plan to rotate first along the proximal segment, and then we transfer that caudal measurement to the distal segment. And because with larger radius saw blades, if we try to measure across the curve, so we're measuring from cranially on the proximal segment to caudally on the distal segment, you're gonna lose. And you might lose a half a millimeter, you might lose a millimeter, and you say, well, maybe that's not such a big deal with a big blade, but all these errors can potentially compound itself. And so, if one were to mismeasure the plateau angle, and now you under-rotate by a millimeter, all these errors will compound. And so we try to be as accurate as we can with each one of these steps.
And it's not exact, but roughly the width of the blade is how much you're going to be short when you go diagonally across the osteotomy. So it's absolutely true. And in a 24 blade, a half a millimeter is about 1 degree.
So I think here you can see now that you can see where the bone has been marked. You can see the osteotomy has been completed, or I guess will be completed. Sorry, we've made our bone marks, and now we're going to continue through the bone, oscillating. And I tend to rotate this from caudal to cranial, because most of the dogs that we see the lateral head of the tibia trails away from the medial head. And so another strategy to avoid having major bleeding complications is avoid sawing from straight medial to straight lateral. You'll see that on your x-ray pre-op. You'll see where that lateral head of the tibia lies. Some breeds of dogs, like we see these pit bulls, they have actually a fairly significant amount of undercutting. So it means that we have to rotate the blade as we're drilling. So there you can see, I hope anyway, that you can see the blade has been rotated. It's not simply going straight medial to straight lateral.
Yeah, and that it's a subtlety of knowing how much bone you have to cut and where it is, which obviously comes with experience. But all these little tips that you're giving, it's very important. Obviously, you have to oscillate the saw or rotate it so that the blade exits the bone. But exiting the bone on the medial cortex is different than exiting the bone on the lateral cortex, which isn't as far caudal.
Yeah, and I guess that's also another maybe argument in favor of elevating, because I'm processing that information, and whether it's with the tip of my elevator, I'm feeling the amount of that trail, that undercutting. Dogs will have differences in shape of their popliteal fossas. Some will be quite flat, some will be quite deep. And so all that information, I'm sort of almost subconsciously processing in preparation for where I'm going to make the osteotomy and how I'm going to rotate the bone.
And you think, well, what's the big deal? But if you cut now into the soft tissues, you've got some extra bleeding and damage to blood supply, and now all of a sudden your infection rate's a little higher, your bone healing's a little slower, then you get some loose implants. And so all these little tricks add up to the lowest possible complication rate, which is really what we're shooting for.
So here, after the saw cut is complete, we're going to pull this out, and you kind of see a little bit of what we're talking about here. The osteotomy is still fairly well aligned. We're not seeing twisting, torsion, distraction of the osteotomy as a result of, I think, a well-placed jig and an appropriate saw cut. And so we remove the gauze. Any issues with bleeding, major bleeding, honestly, I think I usually see that when it happens before the gauze is even removed. It will usually, as the saw finally breaks through the lateral cortex, all of a sudden you see a lot of blood. There shouldn't be a lot of blood, and I hope, and this is not just for this video, I assure you, there's not a lot of blood here, and we don't have a lot of blood on the skin. We don't have a lot of blood oozing out of the site. This should be a relatively clean operation. So we remove the gauze. Some minor bleeding sometimes occurs, bone bleeding, but nothing major.
Russ, this is Tim. I'm sorry. We've got a couple of questions that probably pertain to what we've just covered. So before we get to the rotation and blade application, could we address those?
Yeah, sure.
Yep. So the first question is, what is the difference between the Keon Swiss jig and the Slocum jig?
Well, I don't know. Unfortunately, I can't really speak to the Keon jig. I don't have any experience with it. I have a lot of experience with the Slocum jig, and I think that the Synthes jig system has a lot of advantages in that the jig arms are smaller. I think that the hole that's created for placement of the pin has got this very tight tolerance that I mentioned before. So the 3 millimeter pin fits very snugly. Doesn't have a lot of wobble. And then when we look at the shape of the jig arm, you can see that it's canted. It's not the Slocum jig had a very big, bulky, kind of linear sort of arm. This, you see, there's an angle in it, and that angle allows for clearance of the threaded drill guide in the caudalmost hole in the plate. So there's a lot of advantages, and again, it's kind of subtle, smart advantages to this system. Do you have any experience, Mike, with the Keon jig?
No, I haven't used it, but you know they're also different sizes. The the DPS jig is a bit longer, which means it'll work in a bigger dog. And then, of course, it's too long for smaller dogs, but there's a smaller size. So, they're all slightly different, but and it's like anything, the Slocum jig was the first one made. And then you realize, okay, this is a little too big, this is a little too short, what can we improve? And so I think the more recent iterations of the jigs have improvements that were intentional based on the shortcomings of the previous generations.
Okay, question number 2. How do you pack the lateral aspect of the tibia as well as the caudal? Or do you? No, sorry, how do you pack the lateral aspect of the tibia as well as the caudal?
Yeah. So again, my technique has evolved a little bit. And when I think about how we did this this would be around 2000 or so, is that we did a pretty extensive elevation, and we would elevate the bone laterally with an incision that was lateral to the tibial crest. We would elevate that, and we would put gauze, one gauze laterally, and then one gauze caudally, and we were a little bit more invasive in terms of what we were doing. That was also in the days of non-contoured, non-locking bone plates that we had to bend and twist. And so we would contour the bone plate by hand, and then I would clamp the bone plate with a large forceps through that same lateral dissection. So we would insert one limb of a large Verbruge bone holding forceps and clamp the bone to the plate, or clamp the plate to the bone. Today that's different, and so I have evolved my technique a little bit. I still elevate all the way to the lateral tibial cortex, and I feel that with my elevator, and then I follow up and I feel it with my finger. And so when I'm placing that gauze, I'm making sure that it's going all the way down and in behind that lateral head. So I'm doing it, I think, the same, just in a slightly different way today.
And the last one at this point is, how do you determine the planned location of your osteotomy intraoperatively, in particular in relation to preserving the tibial tuberosity width?
Yeah, so that goes back to our initial digital templating. And when we think about making a centered osteotomy and preserving a mantle of bone, I think the 10 millimeter rule varies based on the breed. Obviously, you can't get 10 millimeters in a Yorkie, but I think that when we plan our centered osteotomy to preserve a large and diverging mantle of bone of that tibial crest, that really is based on our plan. So we then transfer that information based on the position of the upper tibial tuberosity, and we measure with calipers. Where is that to go? And that distance, remember, what you're seeing on the x-ray is not exactly what you're seeing in surgery. And so when we make this small little opening just underneath the patella tendon, is that you're measuring on the x-ray the highest point in the bone. What you're seeing in surgery is really sort of the medial aspect of the bone. There's usually a small little hump there, a small little ridge, a convexity. And that's really where that entry point is. So we're mimicking what we planned and transferring that to the operating table. I sometimes talk about seeing the bone and learning how to correlate what you're seeing in surgery with what you planned.
Yeah, and you can see on this is your plan here, Russ. I've just drawn these distances, and we measure this width of how wide is the tuberosity at the patellar tendon attachment to the cut. So here's the osteotomy right here. And then we measure, as you just said, along the tuberosity. I actually, I look in there, lift the tendon a little bit with a center Homan, and I am looking at the same surface as the x-ray because I've made a little incision and lifted the tendon out of the way. And that's a critical point, because if you measure one thing on the x-ray and measure something totally different even though the numbers match, you've measured a different spot or thing, you're not in the same spot as you had hoped.
Exactly.
And then here, as you've mentioned before, you put your needle in and then you measure down distance 3. So we call these distance 1, distance 2, distance 3, and they're based on our planning. And then we literally make those measurements on the same spots in the bone, on the bone, make little marks with a cautery, and take our saw blade and connect the dots, and that puts the cut right where you had planned. And we just do that using those local landmarks and measurements. And that's why it's so important to have good planning and then have your plan up in your OR, just like this. This is the OR, this is your screen, there's your C-arm, there's your window. I know the OR, I've been there. And you're staring at that while you're marking the bone and saying to yourself, does this bone look like this x-ray picture or not? And if not, what did I make? Where's my mistake?
Perfect. So we'll rotate the bone. We're going to line up our reference marks. I'm going to hold this, and as I'm doing this, I'm actually creating some digital apposition, holding the bone while my assistant then inserts our temporary fixation pin. And the idea with this is it's starting relatively craniolateral on the tibial crest, and it's being driven across the osteotomy and angling it towards the entry of the jig pin. So we're going from lateral to medial and crossing the osteotomy. I drill these high, and I typically have them placed about midway between the osteotomy and the upper tuberosity. We want to avoid, I think, having this temporary fixation pin being both too big and too distal. And we sometimes see where these pins are placed below the tuberosity, and in some cases extremes that then create now a hole. And that hole in the bone will be a stress riser, and it may predispose to tibial crest fracture.
And this is another little reason for the jig. If you tell your assistant, aim right here, just below the jig pin at the medial cortex, now they have a target, right? And so, just like you said, going back to the beginning of the surgery, putting that jig pin in sets the stage for the rest of the procedure. Now here we are aiming our K-wire right at the jig pin.
So we're again going to test fit the plate here. I've now reinserted a 25 gauge needle again to help me identify where the medial head of the tibia is. Sometimes we're going to see, and I mentioned earlier about the amount of bone, a ridge of bone that we'll see, and again, certain breeds of dogs tend to have a greater ridge. I don't do this routinely, but sometimes I will take my saw blade and I'll use it almost as a planing device, a planing tool to take down that ridge. Here you can see us kind of, I think, doing that. We're not removing a lot of bone. We're just taking off the point of that ridge so the plate can sit nicely on the bone. I do elevate and I do identify and understand where both the cranial cortex and caudal cortex are distally. I do that because I want to have the plate centered on the distal tibia.
And then can you just mention the point of reduction forcep?
Yeah, and so that's another thing that we do as a matter of routine. So after the fixation pin has been placed, the temporary fixation pin, I will still hold my rotation pin, and as we're doing that, I have my assistant apply a large pointed reduction forcep to either create or maintain compression across the osteotomy. So you can see here, I hope in the video, there's no gap there.
Yeah. And so you hook it on the jig pin here?
Yeah, and I think depending sometimes on conformation, sometimes it's on the jig pin, sometimes it's actually just behind the medial head of the tibia. I think it varies a little bit from dog to dog, but again, another useful function of the jig is it can be a point around which you can secure that pointed forcep.
And then on the cranial part, where do you put that point?
Yeah, I usually put that just at or just below the tibial tuberosity, and in trying to create, much like we talked about, the vector of compression kind of across the midpoint of the osteotomy.
Yep. Yeah, and in my experience, trying to center that in that little width of the tibia is important because you don't want to have it real medial lateral and potentially chip some bone off. And the angle is important. This is about right. It's not straight cranial. It's not really distal, but it's just slightly from caudal, proximal caudal to craniodistal, compressing the osteotomy in this direction. And it's also important that you have a good pair of these. Some of them have very dull, blunt, big points that don't actually bite the bone. You want a good one that is sharp and pointy, so it precisely squeezes and doesn't just slide around grinding away at the bone. Tim, I see you're back.
I am back. We have a couple of more questions apropos for this time. So the first is, how do we select the size of the temporary K-wire for holding the osteotomy?
Yeah, I'll tell you that in general. I think for most dogs, it's going to either be an 0.54 or an 0.45 inch K-wire. In my hands, it's subjective, and I don't know that there's an absolute. I do think we want to make the smallest hole possible. We want to avoid putting too big of a pin in. I think bigger pins make bigger holes that again make stress risers. Bigger pins might conflict with the orientation of and placement of your drill bit and screws. So it is somewhat subjective, but in a 3.5 case, it's usually going to be either an 0.45 or an 0.54 K-wire.
Okay, and one more is it possible for the pointed reduction forceps to cause damage to the cranial tibia or the tibial plateau caudally?
Possible. Possible is an interesting word. I think it's unlikely. I think is it possible that you could squeeze that so hard that you fracture a tibial crest? I guess I can tell you I've never done that. I think it is within reason. I'd say no, but I wouldn't say it's impossible.
Yeah, anything is possible. But if it's like any tool, right? If you use the tool correctly, it works, and if you don't, you're going to probably have a problem. So, and that's what we were just getting at with the shape and the size. If you use a nice, large point of reduction with pointy ends, and you hook it on the pin and center it here and give it one nice gentle squeeze, you're not going to damage anything. If you've got a lousy pair that's super dull and it takes you 25 attempts to finally squeeze it and you've now chiseled a giant hole in the tibia, it was possible. But that's more technique than instrument, right? It's not the use of the instrument, it was how it was used. So this is safe to do, but like any surgery, you have to do it correctly. Okay, so now we're getting down to it. Drill the arc hole.
Yeah. So we're using our universal drill guide here. We're pressing down on it. So we're going to place this hole in a more neutral location. This is being drilled with a 2.5 drill bit to then receive a 3.5 DPS Cortex screw. You'll see also, and I just want to mention, I never was a K-wire hole user. I never felt the need for K-wire holes. I've kind of become a K-wire user, and I like it with this system because the K-wires, I think they addressed a concern I had, which is K-wire holes that are milled perpendicular to the plate get in the way. They get in the way of my hands, my drilling, my threaded guides. These K-wire holes, I hope can appreciate, are milled at an angle. So when we place them, they are now out of the way of the path of our drill guides and drill bits. So I think that's an interesting subtle feature.
Yeah, and it comes back to engineering. When we added these holes, we wanted to ensure that the threaded drill guide and the universal or, universal drill guide for the slot and the threaded drill guide for the combi hole wouldn't get interfered with by the K-wire, right? Because you don't want it in the way. And so they're angled, and they're also positioned in a spot where they don't decrease the strength of the plate, because obviously putting a hole in a plate next to another hole in the plate could weaken the plate. And so there's a little bit of engineering involved with what's the size of the K-wire hole, where does it go, is it in the right spot to hold the plate still, but yet be out of the way of the surgeon? And so, yeah, a lot of plates have K-wire holes, but a lot of times they're not that helpful. So we tried to make these as helpful as possible. But just like anything, could you damage the bone by putting a K-wire in it? Sure, if it's dull and you drill it for a long time and heat up the bone. So a nice sharp K-wire, make sure you know the angle of the plate so that you don't drill the K-wire into the metal and you follow the angle of the hole, and have a sharp K-wire with lavage so you don't damage the bone. And then, of course, most of the time these are monocortical, just enough to hold.
Yeah,
so they
point
from the bone.
Yeah, great point.
Good. So now we're going to tighten that arc screw. So the arc screw hole is obviously hole number 4. It's the first screw in the shaft of the plate. And Ross, this, we're going to loosen and tighten this. So you're going to tighten this. How tight do you make it?
I make this snug. So I make it snug so that the plate is now no longer moving. And, here we've now got really 2 points of fixation. We have our K-wire and we have one screw. And those 2 points of fixation now should keep the plate from sliding, cranial to caudal, tilting, rotating. So snug, but not white knuckle.
Right. And so I'm just going to stop this for 1 second and point one thing out. So in this case, you've got a K-wire in and we just put in this screw. We don't want to put this screw in a load position in this scenario, because when you snug the plate down, the plate is going to try to move, but the K-wire is holding it still. And so that doesn't work. If, on the other hand, you're not using a K-wire, before I snug down the screw, I would push the plate proximal, let the screw hit the plate edge and find its own spot. So that leaves me as much room in the arc hole for later compression as possible. So the way you do that differs a little whether you've got a K-wire or not. Obviously, you can't slide the plate proximal with the K-wire in it. If you don't have a K-wire, you can move the plate around, angle it however you like, and then tighten the screw. Realign it down the bone, whatever you might want to do. Tim.
Yeah, I would just like to comment a little bit on that design, Mike. It's physically impossible to put that screw in a load position. That arc hole is designed so that you can't do that. It will always be in neutral.
Right, but you can still do it if you pull the drill guide all the way back and don't depress it. It will still, it's not designed that way, but the screw head will now touch the plate and move the plate. Right? So we just have to be careful. The ideal scenario is, just as Ross said, put it in a neutral position in the distal, so to the right side of the hole, just to preserve some distance. If you don't have a K-wire, as you tighten the screw, you just want to avoid letting the screw head slide or letting the plate slide distal, so the screw is now all the way in the proximal end of the hole, because then you can't you can't compress and you can't use the arc feature if there's no room for the screw to move within the plate. So that's the point I'm trying to make. When we're done, we want it to look like this. The screw is relatively distal in the hole, and there's lots of room proximal. If you don't have a K-wire, it's kind of up to the surgeon to ensure that that position is correct when the screw gets tightened. So we were about halfway through this. I'm just going to move this. Yeah. So now this screw, Ross, positioning of this screw.
Yeah. So now this is placed in load, and I appreciate that this is a little bit different than the technique we described previously about the second screw being the number 5 screw. I think this was at the time anyway. This was the original protocol to put the most distal screw in a load position. So we're not pushing down on the universal drill guide. This is going to cause the drill to be most distal, most eccentric in the hole, and then as we place the screw, it's then going to hit that engagement lead-in order to then create compression. And so you'll see that here, and again the same sort of principles with anytime we're sawing bone, anytime we're drilling bone, we're also aggressively lavaging in order to keep this cool and avoid.
Yeah, one other thing to mention, it seems intuitive, but when we drill these, I always drill orthogonal to the plate, both cranial to caudal and proximal to distal. Why? Well, why not? If you drill at some weirdo angle, or you just randomly drill at whatever position your drill is in, how do you remember that exact angle when you go to put the screw in? And you're more likely to cross thread or strip or fracture a cortex. So if you drill perpendicular to the plate intentionally every single time, you know automatically which direction the screw has to go in, and it just takes out one other potential error. So I do see, if you look at post-ops, you see the screws going in all varied directions. It seems like it's totally random. It shouldn't be that way. They should just go straight, unless there's a good reason to not. But in this surgery, there really isn't a good reason.
Yeah.
Okay, so now we're going to put in screw number 6.
Yeah, and you can see that the drill hole is distal in that DCU.
Yeah, right here.
And we're going to insert the screw. I do these by hand. I do not power insert Cortex screws. I have nothing against power insertion. You'll see, I think, when we insert locking screws, I do use a torque limiter, not because we're necessarily tightening these screws to 1.5 Newton meters. It really is more of a prevent you from over tightening the screws. I often say, we're putting in bone screws, we're not hanging drywall. So I have better sensitivity when I put these screws in by hand, and I think we avoid over tightening. So that's just a personal opinion, personal preference thing of how we do these things. We're then going to want to put at least 2 bone screws in the proximal segment. So you can see here we're inserting a threaded drill guide into the number 1 hole.
And there's another important reason why we generally put these in by hand, and we put these in with power. And it has to do with the way the bone is made or built. In the top, it's very thin cortex with a lot of hard cancellous bone. The screw is going to automatically follow the trajectory of the drill hole because that cancellous bone directs it. There's no hollow area for it to go whichever way it wants. Down here, this is thick cortex, really no cancellous bone, it's hollow. Once you go through the medial cortex, you can now change the angle of the screw any way you want and miss the opposite lateral cortical hole because there isn't any cancellous bone that directs the path. So it's much safer to use a hand insertion technique in the distal 3, whereas the anatomy of the bone allows power insertion in the proximal 3 because of that cancellous bone guiding the screw. And it's hard to cross thread or misdirect a screw in the top, but it's easy to do it in the bottom. Okay, so now we've got oh, and I guess we should mention too, this screw intentionally is left loose, right? It's put in,
Correct.
just as it starts to touch the plate, you stop tightening it. You can see it's sticking out still here. We've
Correct.
got 2 locking screws in the top.
Exactly. And so in order to create compression, the first thing we have to do is we have to remove our temporary K-wire. So that will come out. And then once that's out, we're going to very, very lightly, we're going to loosen our first screw, our number 4 screw. And then that will allow us to then tighten the number 6 screw. So we loosen that just a quarter turn, a half a turn to allow it for the plate to move along that screw. And now we tighten the distal one until it's secure.
Yeah, and that's an important point. And, we use that sequence whenever we're compressing and we've already got 1 screw in place. In order for the distal screw to compress, which means the plate needs to slide distally, the other screw that's inserted in that same boat segment needs to be loosened slightly.
Mm-hmm.
So that's the reason we don't make that super duper tight from the get-go, because now we're going to have to loosen it and retighten it and loosen it. So we don't want to super duper tighten it and then potentially strip it as we loosen and retighten. So we put it just tight enough to hold the plate still, and then we loosen it a little bit as we compress. And then I usually will snug it back up and loosen it again before I compress with the next screw.
Yeah, exactly.
Good.
And then I think if we probably can advance to the next video, Mike.
Yep.
And so we're now going to drill the number 5 hole distal segment. Again, this is being, I know my hands are kind of in the way here a bit, but this is again being placed in a load position. This screw hole does give you several options. One option is to place this as a locking screw. Another option is to place it in compression. We tend to double load these. The bone quality in the distal tibia tends to be very good, and the cortical thickness is wide, and bone quality is generally good. I do sometimes put locking screws in here, and the older dogs, again, it's a feel thing, a sensitivity thing. I might put a locking screw in. All the art cases I've done, I've double loaded, and so you see that here. And Mike's already brought up the point. When we start to insert this screw, we're going to need to loosen the other ones, because again, we want the plate to be able to travel, and then sequentially go back and forth between 5 and 6, tighten, back and forth, and then finally secure that number 4 screw.
And one thing we did forget to mention, before tightening number 6, we should take that K-wire out, because the plate obviously can't slide distally as we compress if it's secured by a K-wire. So once you get screw 6 in and you're about ready to compress, that's when you take your K-wire out. It's already done its job.
Yeah, exactly. And I think we saw that in the video, Mike. We saw Lindy taking that K-wire out in order to do that. And so then we're going to insert screw 5, and we're going to compress. So here I'm just making sure that the number 4 screw is a little bit loose, so that we still have the ability for the plate to travel. And sequentially tightening the 5 and 6 screws here, we're giving a little bit of a half turn, loosening it, and and then we're going to tighten in sequence, kind of a little bit in number 6, a little bit in number 5, a little bit in number 6. And then once that's complete, we're then going to finally go back up and retighten the number 4. And you may be able to see even in this video that the position of that screw has now changed relative to the plate hole. You can actually see where it's now traveled.
Great. And it brings up a good point with the technique. And we talked about not over tightening number 4 because you have to subsequently loosen it. The same thing with number 6. It's generating some compression, but let's not make it do all the work on its own. So when you put in 5, you're going to tighten 5 a little bit, go back, retighten 6, retighten 5, retighten 6. So don't make 6 as tight as you finally will until you've got 5 in and tight, because there's no reason to super tighten it only to retighten it again. We can let the 2 screws work in unison to achieve compression, rather than overdoing it with one and having little work to do with the other, because then you might strip one and so on and so forth. So it just comes down to feel how tight is tight enough before moving on to the other screw.
Yeah. So this was just done mostly for the sake of the video, but I still do these things. We put in our last screw in the proximal segment. I double check with calipers. I don't usually do that clinically, measuring from the caudal medial tibial cortex to confirm the degree of rotation. But something I do clinically is I will loosen the jig at the end and again make sure that it freely swings, because if it was freely swinging and unrestricted and not binding before, it should swing freely and be unrestricted after. And so that's what this looks like. We remove our pointed reduction forcep. We remove all of our jig pins and lavage and close.
Yeah, I think we saw that here, double checking the rotation distance and then double checking that the jig still rotates or swings freely. And you can see here the third screw is put in, and whether we put the third locking screw in after all the compression is done, or we put the third locking screw in after screw 6 is snugged up and then we put 5 in last, it's really up to the surgeon, and is there the K-wire in the way, a jig pin in the way, and so on and so forth. So we always compress with at least 2, but that third one can be inserted before number 5 or after. It really doesn't matter. And then here's, these are just still images from your case. And what I hope people can appreciate is that before compressing, you can see number 6 is loose. Number 4 is right up against the edge of the plate hole. After tightening number 6, we're starting to see a small space because the plate has moved distal with respect to the screw. And then after we put in number 5 and we load both 5 and 6, that little gap is now even bigger. And obviously the amount of space between the screw and the plate will relate to how much did the segments actually move. If you've got perfect apposition, they can't really move. So you're going to generate a force, but not see a big space here. Whereas if you had a millimeter gap, you're going to see at least a millimeter of space as the screw travels within the plate hole. Tim.
Yeah, we just had a couple of questions on pins. The first, the temporary fixation pin, the question was, doesn't it interfere with compression?
Well, it would if you left it in place. And I think that was the point I tried to make, and I think Mike reinforced, is that when we look back at the videos, before we started compressing, that temporary K-wire, that was removed. And so it would, unless it was removed. And so that's correct. The K-wire is removed prior to compression.
But it also comes down to, is there actually a gap, right? If you've got perfect apposition and you start tightening this screw, the plateau is not moving. It's just generating a force. So now there's a force between my hands, but now there's not. Did it move? Not really. So what I'll do is I'll tighten number 6 till it's snug. Then I take the K-wire out and then I tighten it a little more, because I don't want to have no K-wire and the possibility of things moving out of position. But obviously, we want to take it out before we fully compress with number 6. It's just a question of when do you do it. And again, if you had a 3 millimeter gap here, yeah, gee, that plateau is going to have to move a long way. Your K-wire is going to stop it. But if you've got perfect apposition, it's really not moving. It's just generating a force. That force can be generated even though the K-wire is in there. Remember, K-wires are flexible too.
And then the second question is about the temporary plate fixation. Do you use just one K-wire to hold it on, or two?
Personally, it depends on the anatomy. I went from using no K-wires to now starting to use them, and honestly, the more I use them, the more I seem to like them. And I really like the features of this system with the angle K-wire. I think that depending on the anatomy and depending on the size, and we get that. In fact, I just did this yesterday, a single session bilateral case in a relatively small kind of pit mix, sort of short stature, maybe a dog that historically I would have used a 3-5 small bone plate. The position of the bone plate distally now becomes very important, and having that centered between the cranial and caudal cortices. So a case like that, I might use two. I think a bigger dog where I don't have those same concerns, I do one. I think every time we make a hole, we're introducing a point of potential problem or failure. So if we don't need to make 2 holes in the bone, let's not. But if we think that adds value, like in a smaller stature, shape, size bone, I think that's why it's there. So I think either's acceptable.
And in addition, the ideal is that the plate goes straight down the bone. But sometimes, even with this plate, the plate is canted on the bone. And that distal more K-wire hole might be on the cortex. And so maybe it's safer just to place the one proximal one. But in a bone of adequate size, they're both over medullary canal, then either is fine. But as you said, I think, the security of one is good. It doesn't go up a huge amount with the second one, but it is a little. So if you find the plates moving and a second one's going to help, then sure, why not? And remember, those K-wire holes are within the plate span, so it does weaken the bone, but it's still protected to some degree by the plate. Good. So in summary, attention to detail mitigates complications. And I guess one point I'd like to make, Ross is a private practice surgeon. He owns his own practice. It's a business. You got to make sure that you've got a good success rate with a low complication rate. He doesn't rush through his cases. He's meticulous to make the best possible outcome. And so I think rushing and best outcome don't necessarily go together. You could see in the video, there was no rushing. This is very meticulous and thorough procedure to try to optimize the outcome. And that starts with meticulous planning, soft tissue handling. You could see that everything was well irrigated. There is no bleeding because cautery is being used. Nice technique with an assistant to try to expedite things, make it efficient, but not rush through it. And then getting back to the implant, the ARC Tplo plate provides controlled and directed compression. Even though it's got the tilted head, it does have a cranial compression force, and that's due to the engineering of the plate. And we want to combine that plate with other techniques like the point of reduction force to maximize load sharing. So we've got a load sharing construct with compression, which should give us the most uneventful healing. And then last but not least, remember that the plate and screw are a system that are engineered to work together. And so just make sure you're selecting a system that works well for you. Tim, do we have any other questions?
So thank you very much. We've still got, we are 23 minutes over time, and we've still got almost every participant still in the room. So we've done a lot of good. So thank you guys very much.
welcome.
Wait, I think we may have a question. Let me just see here. Okay, yes. Is there a limit to the TPA angle that you will use TPLO as opposed to other techniques such as cranial closing wedge?
Yeah, so I can take that one. You know, the TPLO, we've written extensively about the safe point and TPLO combined with a closing wedge and so forth. I think in general, to make it a quick answer, if you look back at the literature on the safe rotation point, which is essentially the plateau being even with the tibial tuberosity, for me, that's the point that's safe to do a TPLO. And then if the plateau angle necessitates more rotation than that, then I would combine the TPLO with a cranial closing wedge in most cases. I think the modified closing wedge works well in some cases too. And if there's a huge varus, valgus, or torsion, then my preference is a biplanar closing wedge or a closing wedge with torsion correction. But that's really the subject of an entirely different webinar, but we can do that one too.
Okay. So, well, thank you guys again, and thank you everyone for joining this webinar. It's been a pleasure.
Thanks, Tim.
Thank you.
Tom.
Thanks, guys.
Recording stopped.
Brian is just going to allow all the participants to leave the main room, and then we can debrief for a few minutes.